Okay, so welcome back. This will be a second talk on the approach to peripheral edema, and I'll be discussing oliguric renal failure today. So, starting off with the underlying mechanisms that may be at play. This is a glomerulus. As you can see, this is the afferent arteriole, this is the efferent arteriole, this is the glomerular vascular bed itself. Fluid, or rather blood, is getting filtered through this, forming a filtrate within the Bowman space. This is the Bowman space, and then moving down the tubules, eventually passing through all the tubules and reaching the urine or the urinary bladder, or the collecting system of the kidneys. Now blood from the afferent arteriole then goes via the vasa recta and ends up in the venules that end up in the renal vein. Now if the urine output has decreased, that implies that one of five things may be happening. The first will be a decrease in renal perfusion or renal hyperperfusion. The second thing that might happen is there may be a problem within the glomerulus. So the glomerulus, we'll just take a deeper or a more enhanced view of the glomerulus. So as you can see, there's a cut section through the glomerulus. This is a single capillary lumen that has been cut end on, and you can see these are the endothelial cells. Okay, there is a single neutrophil within the lumen which is normal, and these are the podocytes. Okay, and between the endothelial cells and the podocytes we've got the glomerular basement membrane, and filtration occurs across this membrane based on the hydrostatic pressure that is present within the capillaries of the glomerular vascular bed. Now this hydrostatic this filtered fluid then passes through the tubules. Now what kind of glomerular pathology would decrease this kind of filtration? So naturally there has to be an obstruction to flow there, and obstruction to flow within the glomerulus could be a result of glomerulonephritis, that is inflammation within the glomerulus. And as you can see, I've shown multiple polymorphonuclear cells or neutrophils infiltrating into the lumen of the glomerular capillary. These damage the capillary endothelium, resulting in secondary thrombosis and obstruction within the lumen of the capillary bed, increasing resistance to flow and therefore decreasing the filtration that is occurring there. The second thing that might happen is there could be direct endothelial activation and secondary thrombus formation within the lumen. So this is a thrombus, and this happens in a group of disorders called the thrombotic microangiopathies, which we'll cover in detail in our subsequent discussion on glomerular vascular disorders. The fourth thing that might happen is that you may have some crystals getting deposited here, or you may have an interstitial infiltrate that then causes damage to the epithelial cells, which then desquamate and obstruct the lumen of the tubule. So this would be called interstitial nephritis. And finally, you could have a postrenal obstruction. Now interestingly, clinically it is rather quite obvious when it is the renal hyperperfusion or a postrenal obstruction that is causing it. So one mechanism that we use, or one group of biochemical tests that we use, is actually we take advantage of the fact that when there is a decrease in renal perfusion or renal blood flow, that secondarily results in decreased GFR, and that decreased GFR causes decreased sodium and chloride delivery to the juxtaglomerular apparatus, resulting in increased renin release and activation of the renin-angiotensin aldosterone system, which then causes preferential reabsorption of these metabolites. Okay, so that results in, so if it is a prerenal AKI, there is very significant sodium reabsorption, urea reabsorption, uric acid reabsorption, and we compare that to that of creatine. How we do that is by taking the ratio of the concentration of the metabolite, say the metabolite is X, in urine, and dividing that by the concentration of the metabolite in plasma, and then dividing the whole thing by the concentration of creatinine in urine divided by the concentration of creatinine in plasma. Obviously, since this is a division, when you invert it or you rearrange the equation, this is what we end up with. So the excretion, the fractional excretion, is basically the urinary concentration of the metabolite divided by the plasma concentration of the metabolite into the plasma concentration of creatinine divided by the urinary concentration of creatinine. So if the sodium is getting preferentially reabsorbed, this particular entity or this particular calculation is what is called a fractional excretion of sodium, or FeNA, and that will be less than 1%. Similarly, for urea, that is less than 35%. For uric acid and lithium, it is less than 7%. Obviously, when you do lithium, it has to be a person who is taking lithium. Now, in case of intrinsic AKI, all of these parameters will be more than certain cutoffs. So those cutoffs are the same as the cutoffs for pre-renal AKI, but just more, except in the case of uric acid and lithium. In case of uric acid, it is more than 15%, and in case of lithium, it is more than 20%, not less than but it is less than 7% in case of pre-renal AKI. Now, on the other hand, we can also just directly check the BUN by creatinine ratio. It is not blood urea, it is BUN. Okay, by serum creatinine ratio. BUN is actually the blood urea divided by 2.8. Okay, so either way, when you calculate this, if it is less than, if it is less, it is more than 20:1. That indicates a pre-renal AKI. So that is because you are preferentially, keeping in urea and not excessively reabsorbing urea because of RAS activation. Now, similarly, you can just measure this urinary sodium also. It would be less than 20 because there is RAS activation in pre-renal AKI, and more than 40 in case of intrinsic AKI. Urinary osmolarity would be increased if there is RAS activation, so that would be more than 500 and less than 350 in case of intrinsic AKI. Urine routine would show hyaline casts in case of pre-renal AKI. These are just coagulated proteins that have gotten dehydrated within the lumen of the thin descending and ascending loops of Henle, because that is primarily where water is reabsorbed. So a lot of water is being reabsorbed. Whatever proteination material was there inside gets concentration and get concentrated and get deposited. This will be variable in case of intrinsic AKI. We'll just get to that. Now, if there is intrinsic AKI, there is actually damage to the tubular lumen. So that damage to the tubular epithelial cells, it causes them to come into the urine. So it could be that their brush border enzymes end up in urine and become elevated in a concentration in the intrinsic AKI. Similarly, low molecular weight proteins are reabsorbed by the tubular epithelial cells. So if they are not functioning properly, their concentrations they'll appear in urine, and their concentrations in urine will increase. So clinically, how do we approach a case of renal hyperperfusion? The first step is you consider possibility of systemic causes. Systemic causes could be decreased intravascular volume, they could be decrease in cardiac output, or they could be a distributive shock. Intravascular volume reduction can be expected if there is ECF fluid loss, which could be either to the kidney or from another site, like say vomiting or diarrhea. Then you could have hemorrhage, you could have third space fluid sequestration, as would happen with severe hypoalbuminemia or CLD. And then decreased cardiac output in this context is then called cardiorenal syndrome type 1. Distributive shock can obviously be of 4 types, that is adrenal insufficiency, septic shock, neurogenic shock, and anaphylactic shock. The second thing that we do is we think of a systemic cause that is causing renal vasoconstriction. So what would that be? That could be sepsis, it could be NSAID, it could be a beta 2 agonist. Actually, this will be these will be the causes. Now, the third thing that you need to consider is that true occlusion of renal artery may occur. The renal artery can be occluded by a thrombotic process, embolic process, or a vasculitic process. Now, importantly, all three of these steps must be considered simultaneously. They are not mutually exclusive. I've just separated them because this is technique. This is how your clinical thinking goes. Okay, but they can be obviously considered. Taking more than one may be present in a single patient. Now, renal hyperperfusion, when prolonged, causes damage to the renal parenchyma. So it is hypoxemia happens, and because of that hypoxemia, there is microvascular damage and there is damage to the tubular epithelial cells. The tubular epithelial cell damage then secondarily causes more microvascular damage. Then the microvascular damage can be at the level of the glomerulus or the medullary capillary bed. That will come into it later. Tubular damage causes loss of the planar cell polarity. The PCP stands for planar cell polarity. That is the clear demarcation of renal epithelial cells as having apical and basolateral cell membranes. So that polarity is lost, and once that polarity is lost, the epithelial cell cannot do most of its physiological functions. This happens because of cytoskeletal damage, and eventually apoptosis or necrosis of the epithelial cells ensues. This secondarily causes desquamation of the epithelial cell and obstruction of the tubule, resulting in tubular obstruction. Then finally, what you end up getting is because of the obstruction, there is back leak, and this decreases the GFR further. Okay. On the other hand, what we have with the renal microvascular abnormalities is we get endothelial and smooth muscle structural damage, and this secondarily causes release of damage associated molecular patterns, which then causes the innate immune system to get activated, and then as a result, you have got your WBCs or white blood cells or neutrophils that come in and cause further damage. Now, in a hemodynamic sense, this kind of inflammation in the glomerular and medullary capillary beds, vascular capillary beds, results in increased vasoconstriction and decreased vasodilatation. So to remember this, I use the mnemonic SEAT. Okay, SEAT, S stands for increased sympathetic tone, E stands for increased endothelin 1, A stands for two things, that is adenosine and angiotensin 2, and T stands for thromboxane A2. Additionally, leukotriene B4 is also produced, which also causes neutrophil influx. Now, finally, this kind of damage to the endothelium causes endothelial obstruction and therefore decrease in renal medullary blood flow, which will then can cause what is known as renal medullary infarction or renal tubular necrosis. Now, if this even worsens even further, you may end up getting renal or cortical infarction. Okay. Now, have intrinsic renal failure as a cause of oliguric renal dysfunction. The most important factor to be considered is actually the urine routine examination. So I use a mnemonic for this. Now, if you have RBCs in the urine, what we look for is there are only two causes, that is glomerulonephritis and thrombotic microangiopathies. Okay, and if we have WBCs or eosinophil urine, the possibilities include I use a mnemonic pig man cap. Okay, so this is specifically referring to the present US president. Pig here stands for pyelonephritis, interstitial nephritis, and glomerulonephritis. Man is specifically for WBCs only, so that indicates your malignant infiltrate and allograft rejection. M for malignant infiltrate and A for allograft rejection. And CAP, C stands for cystitis, A stands for atherosclerotic disease. So that's easy to remember. Then finally, we could have epithelial cells in the urine, and epithelial cells obviously desquamate when either there is interstitial nephritis or your prerenal AKI progresses so much that you end up developing tubular necrosis, as I've just discussed. Now, the same causes also of eosinophilic or WBC or tubular epithelial cells also what are called granular casts. Okay, and that additionally there is one more cause, that is vasculitis. Now, importantly, these entities, when they are severe, that produces RBC casts. Okay, these entities, when they're severe, it causes granular casts. And if it is epithelial desquamation in which is very severe, you can get epithelial casts. So those casts are just more severe variations of this general thing. Okay, so now coming to the four causes of intrinsic AKI that we just discussed, that is glomerulonephritis, microangiopathic hemolytic anemia, on histology, which is called TMA or thrombotic microangiopathy. So all of these entities would then cause oliguric renal failure, and additionally microangiopathic hemolytic anemia almost by definition will require the presence of thrombocytopenia and some degree of intravascular hemolysis. Okay, now this is the schematic of what is actually happening. So we get like we discussed, glomerulonephritis we just saw. Then there are some polymorphonuclear cells infiltrating into the capillary lumen, causing damage there. Then microangiopathic hemolytic anemia, there is direct thrombus formation within these within the small vessels of the glomerular capillary bed. Then we've got interstitial nephritis due to obstruction secondary to crystal deposition or any other type of deposition within the lumen of the tubules. And then we have your interstitial nephritis due to inflammatory infiltrates into the interstitiums, causing secondary damage to the epithelial cells, which then desquamate and obstruct the lumen. So naturally, I would expect the urine RM in these two entities to contain RBCs, WBCs, and those RBCs, since they have to pass through holes within the glomerular capillary bed that have been induced by this neutrophilic infiltration and damage, they change shape, so they're dysmorphic. Now we expect subnephrotic range proteinuria, because actually the glomerular basement membrane functionally is not that problematic, but there are big holes within the glomerular basement membrane. Nephrotic range proteinuria typically happens either when this process is very severe, or more commonly actually when the negative charge in the glomerular basement membrane is lost, which we'll discuss subsequently in our discussion on hypoalbuminemia secondary to nephrotic syndrome. Okay. With microangiopathic hemolytic anemia, what you get is a bland urinary sediment with hyaline casts. Okay, more commonly than RBCs, but RBCs may also occur. So in case of tubular problems, you may have increase in WBCs, epithelial cells, and there is subnephrotic proteinuria. This proteinuria is because the tubules themselves also reabsorb around 1 to 1.5 grams of protein, filtered protein per day. And if that is not absorbed, that will come in the urine, and that is what is that. So the range is 1 to 2. Please note the range in case of nephritis or thrombotic microangiopathy is 2 to 3. Okay. Now There are some very specific clinical scenarios in which these four entities can present, and then there are in basic routine tests you can pick that up. So with glomerulonephritis, if there is hypercomplementemia, it basically indicates there's some kind of complement activation occurring. Depending on what type of hypercomplementemia it is, that is C3 plus C4 hypercomplementemia, isolated C3 or isolated C4 hypercomplementemia, the differentials change, and we'll talk about that in the next discussion in this series. If there is thrombocytopenia with or without leukopenia, there is a possibility of lupus nephritis naturally. Now, please understand this thrombocytopenia could cause confusion with microangiopathic hemolytic anemia, but it is the entire clinical picture that is more important than just the presence of thrombocytopenia. Okay, then you could have eosinophilia, particularly in eosinophilic granulomatosis with polyangiitis, that is Church-Strauss syndrome. Sometimes in polyarteritis nodosa, around 10% of PAN, but PAN is a rare entity, very rare. Okay, now increased serum globulins can happen with cryo, and so when you are suspecting glomerulonephritis as the proximate cause, that is when you have oliguric renal failure, plus you have active urinary sediments, plus you containing RBCs and WBCs and subnephrotic range proteinuria. In that situation, we must always send serum complement levels, that is C3 and C4, and you must always consider the possibility of cryo in the correct clinical scenario. That is, there is a triad, that is peripheral neuropathy, skin lesions, as well as the presence of bilateral symmetric ankle arthritis. Okay, so that triad, if it is present, you send that as well. And in case of microangiopathic hemolytic anemia, if there is severe reduction in platelets, that indicates that the process is starting within the capillary bed lumen. Okay, and it is not specifically affecting the renal capillary bed, so the creatinine may be relatively normal. That is usually less than 2 milligram per deciliter, and then that indicates that it's likely TTP or thrombotic thrombocytopenic purpura. Why and how we'll discuss in the discussion of glomerular vascular disorders. In APLA, on the other hand, you get a mild reduction in platelets. There is thrombocytopenia, but it's not very severe. On the other hand, you have very significant proteinuria, or you may have very significant proteinuria. Okay. Then with interstitial nephritis, tubular lumen obstruction can occur with tumor lysis syndrome. Now, tumor lysis obviously, or rhabdomyolysis. In this situation, there is cellular lysis. So the metabolites that are accumulated within the lumen of these cells come into the serum. So there is increase in serum potassium, increase in serum phosphate, increase in uric acid, and a decrease in the serum calcium levels. Calcium decreases because it binds to phosphate. Now also you have an increase in AST because that is non-specifically present in most cells, and this can also indicate hemolysis, but hemolysis can also cause pigment nephropathy. Now, if you have an increase in serum globulins with or without increase in serum calcium and normocytic normochromic anemia, you can also suspect myeloma kidney, multiple myeloma as a proximate cause. Eosinophils may be present with interstitial nephritis secondary to infiltration. That indicates drug-induced or allergic interstitial nephritis. Now, hyaline casts don't always imply hypoperfusion. You must think past only renal hypoperfusion when you see hyaline cast. So P just stands for prerenal AKI, but AST, this stands for A for your renal artery arterial problems, that is thrombosis, embolism, or vasculitis. S stands for scleroderma renal crisis, and T stands for thrombotic microangiopathy. As I discussed, it is more common to have hyaline casts in TMA than it is to have active urinary sediments. That helps you differentiate it from your glomerulonephritis. Now, intrinsic renal failure also occurs in two specific special situations. One is post-surgical patients. Now, post-surgical patients most likely at risk are those who are undergoing intraperitoneal procedures, those undergo cardiovascular bypass, cardiopulmonary bypass, and those that are undergoing vascular procedures with aortic cross clamping. Now, usually the mechanisms are multiple. That is, there is hypoperfusion, there is extracorporeal leukocyte activation when you use a heart-lung machine, there is atheroembolism, and then there is hemolysis resulting in pigment nephropathy. On the other hand, you can have post-contrast induced nephropathy, not CT scanning. Pardon the mistake. So this happens due to occlusion of first the small vessels proximal to the glomerulus, resulting in initially a decreased vena. Although at this point most people don't diagnose it, so normally it is said that the vena is not decreased. Okay, and then deposition of contrast in the tubular lumen, resulting in that is specifically the thin descending and thin ascending roots or loops of the loops of the this thing, the loop of Henle. Okay, and secondarily, regeneration of reactive oxygen species that damages the tubular epithelial cells and the microvasculature around it in the vasa recta, causing ischemia of the outer renal medulla. Now, ideologically, this could be iodinated contrast. Nowadays, we use isoosmolar iodinated contrast. Earlier, we used to use hyperosmolar. Isoosmolar is much less likely to cause this. Use of MRI contrast, although is not at all as common, and use of soral sodium phosphate, which is used as a bowel purgative, usually for bowel preparation prior to colonoscopy. The risk factors are presence of diabetes mellitus, CKD, CHF, and multiple myeloma related renal failure, because all of these entities put renal perfusion at require afferent arterial dilatation in order to maintain renal perfusion. So there is significant RAS activation, and that RAS activation causes the contrast that is within the lumen of thin ascending and descending loops of Henle to actually get concentrated more. So as a result of that, you end up getting deposition there. Now, clinically, the serum creatinine rises within 24 to 48 hours and reaches a peak by around 3 to 5 days. It's not really that there is a delay, but the thing is, we know what is causing we have presumed what is causing the increase in serum creatinine. So we monitor carefully, and then just like any other AKI, it takes that much time to rise. Okay, so this is the classical clinical presentation. Now, finally, we'll just talk about some definitions. That is the definition of acute kidney injury. I've been referring to, even the talk is termed oliguric renal dysfunction. I have not used the term acute kidney injury. That is on purpose, obviously, because I don't want you to, become very, very finicky about the timing cutoffs. Okay, so the definition basically requires any one of the three following entities: an increase in serum creatinine by 0.3 milligram per deciliter from baseline. Again, you need to know baseline values within 48 hours. An increase by more than 50% over the baseline, that is more than 1.5 times, which is known or is presumed to occur within the prior 7 days, and a urine output that is less than 0.5 ml per kilogram per hour for 6 hours. So this term has been actually included to enhance the sensitivity of the definition. Now, staging wise, we can stage AKI into 3 stages: 1, 2, and 3. So, 1, we can use how much is the elevation in creatinine to do this. So we compare it to the baseline creatinine. It could be 1.5 to 1.9 times, that would be stage 1. 2 to 2.9 times, that would be stage 2. 3 times or more, which is stage 3. Second thing that we use is the absolute rise in creatinine. That is, if it rises by more than 0.3 milligram per deciliter, that is stage 1. And if the absolute value crosses 4 milligram per deciliter, that is automatically stage 3. Now, if the patient at any point requires renal replacement therapy, that is hemodialysis of any sort, that is also stage 3. In children, that is patients less than 18 years of age, there is a decrease in EGFR to any decrease in EGFR to less than 35 ml per minute is considered a stage 3 AKI. So we use EGFR in this situation. And urine output can also be used, and this enhances again the sensitivity. So less than 0.5 ml per kilogram per body weight for 6 to 12 hours is the same as the definition used for this thing is for AKI in general, is stage 1. Just it is 12 hours, up to 12 hours. Okay, stage 2 is if that same problem happens for more than or equal to 12 hours. And stage 3 is, now this note the 0.3, it is not 0.5, 0.3 ml per kilogram per hour for more than or equal to 24 hours, or anuria, which is typically defined as less than 50 ml of urine output per day for more than or equal to 12 hours. So that's how we stage and how we define it, but please don't get hung up on definitions. These definitions are meant primarily for usage in first work clinical trials and for uniform, making data uniform in that context. So it's not necessarily important to use these clinically. The clinical context is very, very important. Okay, so thank you, and I'll see you in the next talk.